the AML treatment paradigm has evolved in the sense that we have a clearer understanding of prognostic markers and a clearer understanding of genetic targets that, can be effectively targeted in combination or as single agent therapy. So I think that we've seen some advances with these combinations that I mentioned before, for example, with FLT3 inhibitors in combination with chemotherapy, with gemtuzumab, and certainly, the development of IDH inhibitors and other, second generation FLT3 inhibitors are certainly very encouraging. We have, some very exciting new agents on the horizon as well, such as menin inhibitors. So I think the future looks quite bright for targeted therapy. As far as trends of treatment, I feel as though we are seeing a trend towards more patients receiving a less intensive chemotherapy, a less intensive therapeutic approach up front with the success of HMA plus venetoclax. I think that it's a therapy that requires quite a bit of fine tuning in complex management from an experienced team, and it's difficult in some cases to manage patients with HMA venetoclax, especially on the outpatient or community basis. But it is effective therapy for sure, and it's exciting to think about combining it with other agents and potentially comparing it against more traditional chemotherapy to get a better understanding as to which patients benefit from one versus the other. So I think we are seeing movement towards, HMA venetoclax-based therapy in a large segment of patients. And at the same time, we're seeing novel combinations that include novel therapies being added to both induction chemotherapy and HMA venetoclax regimens that I think are moving the field forward. So it's a pretty exciting time, I think, for those of us that treat AML. There's a long way to go, but there's definitely movement in the right direction, improving outcomes slowly but surely.